Actually, we started the topic of uh, perioperative myocardial ischemia, and we to cover up or to reach up to that point, we just try to just chalk down the factors which are responsible for maintenance of myocardial oxygen demand and supply ratio. Okay, and we couldn't complete it yesterday, so I will just try to um, cover the rest of the things which are included in this topic. Okay. um, Sumera, just tell me what are the cardiac enzymes, because how, like my question is how we can pick a patient with possible myocardial ischemia during anesthesia, and like how can we pick a patient if I are to ask you this question, that what could be the sign and symptoms of possible ischemia under anesthesia and in awake patient?
Sir, under anesthesia, patient may have a hypotension, sweating, and there on ECG there will be a ST elevation or ST depression with U wave,
Okay.
and due to hypotension, there can be decreased cardiac output, so there can be decreased end-tidal CO2, and patient may be cold periphery.
If you could
And,
organize it, it will be easier for you not to miss anything. Okay, if you just try to just see that there will be some
Okay.
symptoms. Okay, and symptoms maybe are like even in awake patient, maybe the presenting symptom is not actually chest pain, it is actually epigastric pain, burning. You will hear from a number of people that when they presented with the ischemia, actually the pain is in the abdomen. Am I right?
yes.
And in especially, for example, if you have a patient with diabetes, okay, especially in that patient, you might not find the chest pain. You might have maybe signs of failure like sweating. Patient may be like a feeling of unwellness rather than specifically chest pain. Okay, so
Yes,
like
sir.
because we discussed before that sequelae of ischemia is in the form of regional wall motion abnormality leading to uh, this one hypokinesia and then akinesia. Okay, and if it is severe, it will result in failure, like left ventricular end-diastolic pressure will be increased and patient will go in pulmonary edema. In the same time, there may be some arrhythmias. Okay, so like if okay, now if we just focus on the symptoms which may be there in the perioperative period. Okay, so you have a patient under general anesthesia. So what can be the symptoms during general anesthesia? Yes, what could be the symptoms under general anesthesia? Yes, Sumera.
Sir, regional anesthesia like same like sweating
Okay.
and cold peripheries,
Okay.
hypotension,
Mm-hmm.
and on ECG there can be ST elevation or ST depression with U
Mm-hmm.
wave, and there could be arrhythmias, bradycardia, tachyarrhythmias.
Depending on the wall being involved, there may be symptoms may be ranging from any bradyarrhythmias or signs of heart failure. Okay, if you have any like lines, invasive lines like CVP or pulmonary artery catheter, there may be some elevated filling pressures. Okay. Okay. So what will be the if you have the ECG on this one monitor, can you just say by a surety, because ST changes will not be accurate, or you cannot comment wholly solely on in the form of so if you
So then we
have
can go for 12 lead ECG.
12 DCG, any other way? Any other way? Have you heard of CM5? There is a special
Yes, sir.
arrangement
CM5 configuration.
which will be diagnosing the ischemia. Okay, like which will be more accurate than this one, and of course you can confirm it with 12 lead ECG. Okay. So there will be changes if you do the 12 lead ECG. There will be significant elevation or depression according to the what pathology is going on in the relevant leads. Yesterday we talked about the relative leads for 2-3 AVF for inferior lead and 1 AVL V5 V6 for lateral lead. Okay, and for anterior lead, anteroseptal lead we discussed. So acute MI, in addition to those things, there may be symptoms, there may be like ST elevation. Okay, and Q waves, they have written it Q wave, but actually it will not be that much acute. Okay, and some words about the this is a scheme which they will be doing. Okay, so what about the enzymes, cardiac enzymes? What enzymes
Sir,
you
during ischemia, cardiac enzymes can be increased or decreased, and
okay.
more sensitive are troponin T and I.
What are those enzymes?
They can raise. Yes, sir.
What are those enzymes? Troponin. Like if I want to, because practically we say that troponins are more sensitive. Am I right?
Yes, sir.
So troponin I and troponin T, they are raised earlier as compared to CKMB. Okay, but I was just looking at it here, that you will see that if there is because they will remain high for a longer time. Okay, so if there is reinfarction, you may not be able to pick it. Okay, because they can remain high up to 10 days. Rather, while CKMB will rise and come back earlier. Am I right?
Yes, right, sir.
So this question may be asked to you when they are they are asking you about especially in long case, Sumera. This question may be asked to you in the long case, and they can ask you, I did not find that you should be knowing exactly the hours, in how many hours they start to rise and in how many hours they peak. Okay, and when they come back. I couldn't find
Okay, sir.
appropriate slide for it, but you should be knowing about it. Okay, so what you will be doing now, we have discussed a number of things related to how to pick it, what can be the factors, how can you avoid it. You will be giving a balanced analgesia and a balanced anesthesia. You will be chalking out. That's what we have done up till now. Okay, now if you have found it, what will you do? It will be your approach. Yes, Arsalan, you were saying something, please.
No, sir, I just mentioned the enzyme. You already tell about the sensitivity and reinfection, in which we observe enzyme, we look for reinfection and the most sensitive.
Okay,
That's
so
all.
if I ask you this question, that if you want to do this one manage this patient, how will you manage? Like you suspecting or you found it to have ST elevation during the anesthesia. So what will you do?
So
Yes.
we try to stabilize the blood pressure by giving, first of all, we look for which MI wall is involved. And according to that, we plan our treatment to normalize the blood pressure and give inotropic support according to the situation.
Anyone can improve this answer? Yes.
Sir, once we have picked like there is a MI, then we will go for airway breathing and circulation, call for assistance. We will inform the surgeon,
Inform the
and then we
surgeon,
will
call for help. This is, default answer. You will be you will be increasing the FiO2. Okay. You will be you will be trying to maintain the hemodynamics as he told, and you will be looking for any hemodynamic instability, because now you may or you may not have a similar hemodynamic instability in every patient. Okay. So you will be just observing. Okay. And your approach will be airway breathing circulation, and you will be targeting to the same factors which we discussed, that you will be trying to avoid you will try to improve the improve the coronary perfusion and avoid the factors which increase the demand. So okay, so that may be with the according to the blood pressure, you will be giving beta blockers. You will be starting this nitrates. Okay, you will be doing 12 lead ECG. You will be getting the help of cardiologist. If and further management will be according to the scenario. You will try to, if the surgery is going on, you will have to, because of course you cannot immediately send the patient to cardiology suite, but you will try to just abandon the procedure as much as possible according, okay, again to it will be depending on the scenario which procedure is going on, okay, and what stage of procedure it is. But at that time, what you can do, you can put NG tube, and you can give aspirin. Am I right? What will be the pros and cons of doing this? Yes. You see, that's what they have written here. Okay. And then further management. What you do in post cardiac resuscitation care, post cardiac arrest resuscitation, what you do?
Sir, we will monitor the patient's hemodynamics. We will check the hemodynamics. We will send the cardiac enzymes, and then we will repeat the cardiac enzymes, and we will give the 100% oxygen to the patients, and we can go for cardiac consultation.
Okay, so the same things, you will be trying to maintain the sinus rhythm. You will try to avoid the stress. You will just try to have normovolemia. This is actually, you can say in any patient, if you want to have like I label it as my best friends. Okay, so whenever you are telling the goals of management, if you are not sure what exactly in it, these things you can tell in any patient here. Normothermia, normotension, normoxia, normocarbia. What else? Normovolemia. Maintain sinus rhythm. Maintain cardiac filling pressures. Okay. Avoid sympathetic stimulation. I have chalked it down in the anesthesia plan file. I will show you later on. But actually, these are the things which you will be doing. Okay. And if the same thing which we discussed, that if, for example, if it is going in shock, you will be starting the inotropic support. Okay, and the main the aim of therapy will be revascularization. Okay, either in the form of thrombolytic or in the form of PCI. Okay, according to the scenario. Okay, so the things which you can mention according to the scenario, that you should be knowing these numbers, which is actually these are there in the acute coronary syndrome algorithm of American Heart Association as well, that you just try to have PCI or fibrinolytic therapy at the earliest possible time. Okay, and these are the actually too much details, and you may not be needing to know all these things. Okay, okay, so inotropic support, you can have dobutamine, but you see dobutamine will be causing tachycardia, so you have to consider the side effects as well. Okay, if you have the right heart failure, milrinone will be the drug of choice. Okay, and norepinephrine, if the patient is having like decreased SVR, in that scenario, norepinephrine will be the choice. Okay, the other medications you can use according to the need. Okay, what else? Yes, you know what can be the like if patient survives from acute MI. Okay, what can be the sequel, like what can be the resulting thing? It may be in the form of valvular regurgitation. It may be in the form of left ventricular failure. Okay, and patient may develop arrhythmias. Okay, and if there is, for example, involvement of conducting system of heart, there may be a need of pacemaker. Okay, so this is what you will be doing, and certain terminologies which you should be knowing. What is recent MI, what is acute MI? We have discussed a number of times, and this acute MI is within 7 days, and recent MI is within 1 month. Okay, so just a second, actually. So what will be the considerations in the post-operative period? Just give. Yes. Actually, acute coronary syndrome is a big topic. What is different types of angina? Ischemic, like stable, unstable, you know about it. Okay, STEMI and non-STEMI, these are the terminologies which you should be knowing. We have discussed, actually. I will just roll through. We will try to find out any chest pain, syncope, palpitation, dyspnea, sudden death. Okay, and it is severe, constant, retrosternal, spreading across the chest. This is the typical, but there may be different in the amplitude. Okay, and it may be associated with sweating, nausea, pallor, dyspnea, and anxiety often present. Okay, waxing and waning of symptoms, that may be exertional. Okay, and we have discussed before as well that whenever there is ischemic heart disease, you should expect peripheral vascular disease and cerebral vascular disease. Okay, and that's why, just for your interest, that whenever a patient is going for CABG, before that actually they do carotid Doppler. Can anyone tell what may be the reason for it? Why they do carotid Doppler before cardiac surgery? Yes, Sumera?
Sir, there can be atherosclerosis of the carotid arteries.
Okay.
During CABG, there can be decreased perfusion to the brain.
Why? You are right.
Sir, due to
But how can you
atherosclerosis,
defend?
there is a narrowing of the arteries and maybe any thrombus formation.
Actually, this is also related to the pump. Okay, because patient will be on pump for 2 to 3 hours. So maybe if the patient has already cerebrovascular disease, the two systems are needed to be checked. One is kidneys, okay, and one is the cerebral vascular system. Why? Because maybe the ischemia will be if there is some baseline ischemia, okay, because there will be less perfusion during the pump circulation. There will be less oxygenation of the brain. So maybe patient after cabbage may ended up in having ischemia. Am I right? Cerebral ischemia. So that's why they document it, they label it before it, and if, for example, if needed, maybe they will go for carotid endarterectomy, or they will plan accordingly any intervention needed in the cerebrovascular tree. Okay, so that's why it's important. So this is one thing, and that's why the concept of off pump cardiac surgery came. So that's the advantage of off pump cardiac surgery, that you can avoid the this renal problems, and you can avoid the ischemia. But the problem with that one is that because of patient not going on the like the heart is still beating, okay, and so there may be a problem in the number and the quality of the graft. So that's why maybe in Pakistan, when I was working in cardiac anesthesia, I saw a lot of beating heart surgery. But when I came to Saudi Arabia, I was just astonished that they are not doing it in even the biggest of the centers. They are not doing it off pump cardiac surgery unless indicated, because actually if you are doing off pump and you are compromising the graft, or you are compromising the quality of the graft, number or quality, actually this will not be a beneficial thing for the patient. Okay, so this is just I wanted to share this information. Okay, so what else? History, ECG. So if you want to explain, you can say there will be history, or there will be clinical sign symptoms. Okay, and biomarkers. That's what we discussed. Okay, so immediately you will do the 12-lead ECG, oxygen via. Actually, we have discussed all these things. We will just have a quick review. Okay, and so you will be increasing the oxygen by whatever way you can. Okay, and your approach will be airway, breathing, and circulation. Okay, and then you will be doing at either beta blockers or nitroglycerin, sublingual or by any route. Of course, you will be considering the hemodynamic status of the patient. And does anyone know about basal gyrus reflex? What is basal gyrus reflex? People going for EDA, Aditya. What is basal gyrus reflex?
Actually, it's the inspiration. With the inspiration, there is change in the heart rate, and it causes some arrhythmic changes during the inspiration. I don't remember it properly.
Yes, actually, maybe it is because of reflex
Sir,
bradycardia.
during a hypertension, usually there is
Yes, please.
sir, usually during hypertension, there is a tachycardia, but during in this case, with hypertension, there is bradycardia.
No, but why it occurs?
Sir, why?
That's my question. Yes, Tayyab, you were saying something, please.
Sir, basal gyrus reflex is very similar to vasovagal reflex or vasovagal shock. Sir, is actually it is related with the vagal dominance.
Okay. And it occurs in case
There
severe
are
hypovolemia.
severe hypotension. Okay, sir.
Hypovolemia. Yes, it occurs in hypovolemia as well. Because usually the
Okay.
opposite, there is an opposite reflex to it. If there is an increase in ventricular stretch, the heart rate increase. What is that reflex? I don't, Bain-Bridge reflex.
Mary?
No, Bain-Bridge reflex. Okay, so it is
Yes, sir.
actually opposite to the Bain-Bridge reflex. Okay, just a second, please. Okay, so we can give aspirin. Okay, we can, if the patient is slept, you can give aspirin via the NG tube. Okay, and we will be doing clopidogrel. Okay, so what is the mechanism of action of clopidogrel? It is acting on platelet ADP receptors, and it is inhibiting the platelet adhesiveness, like clump. It is stopping the platelet plug formation. Okay, and then beta blocker we have discussed before. It is decreasing the myocardial oxygen demand and decreasing the heart rate, in decreasing the stress on the heart. Okay, if the failure occurs, you will be using the this one. Not only you have to treat the pulmonary edema, and you will be decreasing the pulmonary vascular resistance. So even morphine has a role in it. Okay, and you will be supporting the blood pressure with the inotropes if needed. Okay. Okay, so what will you be doing? You will be targeting the blood pressure, and the further management will be according to the scenario. You will be getting the help of cardiologist. Okay. What else? Okay, you will be, or at the same time you will be doing workup on the differential diagnosis. Okay. If left ventricular failure occurs, you might be needing this intra-aortic balloon pump, which you using in low perfusion after MI. Even they are placing it during the cardiac cath, when they do it in the primary, when the patient is following the ACS protocol and they are bringing it for cath. So another practical thing I will tell you, that during when they reopen, there is reperfusion. Okay, so because of reperfusion, sometimes there are severe arrhythmias. If you are giving monitored anesthesia care, because Sumera, this may be also a question even for Aditya, for you as well, in EDA and even in our exam. They can just change the scenario and they will be telling that you are monitoring a patient with acute MI in the cardiac cath lab. Okay, so what are the problems you can see? Even in awake patient can go in ventricular fibrillation when they have opened the vessels. Okay, so they nothing to be worried about. You already have attached defibrillator pads on it, and you need to defibrillate the patient. So, but you should be you should have be ready for any unwanted cardiovascular sequelae, even while you are not doing anything. They are doing the cardiac cath and you are observing it, and you may be ready for any further decompensation which occurs. Okay. So this is actually too much details. This is available in the link which I shared in the link as well, in the YouTube link as well. So this is what we have discussed before: 2-3 AVF for right coronary artery or posterolateral branch of circumflux. Okay, anterior leads V2, V3, V4, LAD or diagonal branch of LAD. Okay, lateral 1 AVL, V5, V6 circumflux. So this is you can review from it. Okay, And what else? Actually, maybe we will find here the some. Any question? Because we have almost covered what I wanted you to know about the factors, because actually, this is one of the most important, even as practical conduct of anesthesia, because all our shopping, all our shop of anesthesia revolves around the maintenance of myocardial oxygen demand and supply ratio. Okay, so as a good anesthetist, you should have a very good concept of it. And I just give you a practical tip, that if you want to check it out, how good is your anesthesia, your depth of anesthesia during the stress of surgery. Like, for example, you have intubated the patient, just observe how much heart rate change occurs. Similarly, now you have intubated the patient, and there will be a window period in which you are giving the anesthesia and there is no surgery. Okay, there is no surgical stimulation. So especially in the patients with autonomic dysfunction, as occurs in chronic hypertensive diabetic patient or any other patient like that. Okay, so the blood pressure will fall down a lot. Okay, and maybe you are decreasing the depth of anesthesia, but you don't anticipate that before anesthesia, before INCN, you need to increase the depth again. Okay, and if you manage to have tachycardia again, so this will be detrimental. So it is actually, in somewhere it is also mentioned as roller coaster phenomena, that you are going up and down and up and down. So what your target as a good anesthetist is that you avoid the roller coaster phenomena. Okay, so I think it is enough for this topic. Any question, anything you want to discuss, please feel free. Anyone who was being asked this question before in any exam? Yes, Aditya, would you like to share something?
No, I have not been asked this about MI.
And actually you should be knowing, because when they are taking the oral part, suddenly they will ask you, what is the mechanism of action of clopidogrel? What is the yes, by the way, I asked you a question. What is the mechanism of action of heparin?
It binds to inhibits factor 10.
Yeah,
And
this is one.
Anticoagulant.
It actually facilitates function of antithrombin 3. Okay, antithrombin 3.
The 2, I think so. Antithrombin
sorry?
2A. So
2A
I'm
what?
not sure, but I think
No.
inhibit the function.
Okay, no, actually it's not like that. It is increasing the activity of antithrombin 3. Okay, it is increasing the activity of antithrombin 3, and yes, it has effect on factor 10 as well. Okay, I have a question. This is also a practical question. If you give heparin, okay, and there is no effect, because this question is a well-known question when the poor person in anesthesia residency goes to cardiac anesthesia floor. And this is a question which I was being asked, and I didn't know anything about it at that time. But now I discuss this question again and again, because this is a scenario which you should be knowing. That if you give heparin and there is no effect, because usually in cardiac surgery, they do a baseline ACT, okay, and then they give heparin, and then they repeat ACT, and it is going around 4 to 5 times for clinical anticoagulation, and after that they go to the pump. Okay, so if you give heparin but you did not achieve the required ACT, what is the reason and what will you do? Yes, anyone has got any idea?
Sir, there may be antibodies against heparin.
No, this is something else. This is
Oh.
HIT. This is HIT. I will tell you this. This was the second point which I was to tell.
It is by heparin and thrombocytopenia.
No.
No,
This is
maybe antithrombin 3 is
deficiency.
not working proper.
Yes. Okay.
Yes, yes.
So actually, in these patients, you will be surprised that you are supposed to give you are supposed to give play FFPs. Okay. You are supposed to give FFPs, and after that you will give heparin, and then heparin effect will come. So this is our question. Then another question which we have already mentioned is about HIT. That usually the people who are attaching the invasive blood pressure line, they are putting heparin in it. Okay. So do you think heparin should be put in this normal saline this preparation in the closed circuit which we using for invasive blood pressure? Should we put heparin or no?
Yes, it should be put because it prevents formation of clots.
Yes. So actually, in it's a risk factor for development of HIT. Okay, you are exposing, because you don't know how many molecules are required to initiate HIT. Okay, so actually recent guidelines is that you don't need to put it. Frequent flushing of the line and keeping adequate pressure, okay, is more important than putting heparin. Okay, so there are actually two schools of thought. Some people still use it, but it is recommended not to use it. Okay, so this is what I just wanted to share. Fundoparinox or lapuridine, these are the two medications which are used if there is HIT usually. Okay, and you should be knowing, because this question come in MCQs. It is indirect factor 10A. I never remember it. I accept this online. I'm not able to recall the name of these medications. They are terrible. Rivaroxaban, dabigatran, fundoparinox, and there are some other antiplatelets, that's similar name. So it is very difficult sometimes, but you should be knowing about it because they will be asking you in the exam. Okay. So this is another group of antiplatelet medication, glycoprotein 2B3 inhibitor. Okay. They are these agents override the platelet activation caused by plasminogen activators. Okay, improving patency rates and allowing better perfusion. Then beta blocker we have already discussed, and summary. Aspirin, nitroglycerin, heparin, beta blockade or calcium channel blocker, and supportive treatment. Okay, hemodynamic instability. Okay, I think we will finish here. Okay, and because actually I just wanted to tell you that few days are left before Ramadan will start, and maybe during Ramadan I will not be able to conduct the classes, so there will be a gap, and then we will restart after this month. Okay, in between, if you want to ask any question, I am available all the time to all of you. Okay, and I will be very
Sir,
happy
but
to.
our Viva might be in between Ramzan or just after Ramzan.
I will try to whenever, because right now I'm just doing it daily. Maybe we can do it on weekends according to my availability. Okay, you can arrange, and then I will be on the passive side. You can arrange a topic and I can conduct the Viva for you. Okay. So anybody, thanks a lot. And like all of you, if you want to access to all the recordings which are there, you can search on the YouTube channel. Okay, and this is the link which I share number of times. So these are the basic, because actually articles I have put it in the separate link with the year wise and topic wise, but here you can find all the books. There are basic sciences books, review books. Okay, MCQs. In MCQs world, you will find basic sciences MCQs, best choice MCQs, clinical sciences MCQs, and if you open it, and you will find a number of books. Okay, so you can use it like a bank, and you can start with which I have number 1. It is my personal choice. All books are alike. And by the way, remember one thing, all the books have mistakes. All the books have mistakes, especially the people for European diploma, because I did it and I actually 1, 2, 3, maybe 5, 6 books I did it from this. People are attracted towards this Cubase. I tell you something, Cubase is developed in 90s. So it is around 30 years. This book, if you see, it's maybe 30 years old book, but you will see here maybe the year. You see, just have a look. Just have a look. It was published in 1997. This is 2022. So, but because the European people, they have not changed yet, so people are attractive towards Cubase. Okay. So I would suggest you, even maybe there are some other latest books, it is better to do it. Yes, basic sciences does not change much, but what is difference between in these books and these, like this one, I found this book as the best one. Even the people from Pakistan who are appearing in the choose the best question, I will suggest you to read these books. Okay. Yes, you will not find the darling way of what is the answer, but you will learn a lot. Okay. And actually learning MCQ knowledge is the base of everything. Like if you read this MCQ and you have 1, 2, 3, 4, 5 points about ketamine. Okay. And I guarantee you that if you will read another book, second book, and then third book, you will find around 25 points about ketamine. And then any point will be asked in the exam and you will know everything. This is the way. I did not read any book I tell you other than MCQs books. I just read the MCQs book, read the explanation, like you will find the explanation here. Okay. And actually you will find the source as well. Okay. So if you want to go to find out this CEA CCP article, you will find it here right now. For example, if you see 2003, you will find it here because the name is changed now. Its name was before CEA CCP. Now its name is British Journal of Anesthesia Education. So you will go to this link and yes, year-wise articles, and you will find it BJ Education. I have arranged all for you, but unfortunately nobody bothers to have a look. You will find it here. Okay. So this is the way to, because learning is actually, people want shortcut. Okay. They ask me, when they contact me, they've asked me, sir, please tell me one book. So actually there is no book which will be giving you a good grip on the subject. If you want to know the subject in post-graduation, you are not in class 5, that you will have some cooked recipe. You will put just like our women do, like now the ready-made mix, or open YouTube channel and they were just putting the things like that. There is no shortcut like that. Okay. You have to work hard. And this folder, you will find questions, a number of questions I have dissected. Before I started this taking these sessions, I used to note down the question and share with the people, and people used to ask, sir, where are the answers to these questions? So actually they don't want to work at all. So actually, even if you are knowing, I'm telling you, these are the points which you should be knowing about that topic. You just read that source and you will be knowing. This is what another source which I just compiled. Actually, when I was studying, I just made a list of it. And actually, this is one way, not absolute, but it is a good way to revise the topics. Okay, I just make it like 150 topics and you can cover a number of things through it. Okay. So this is what I was telling you in the anesthesia plan. And if you, I have stressed too much about this thing. These are the symptoms like history. Then this is related to examination. You can access this. And this is how to make a plan. Okay. You can read about it and you will find it. If you know this as a junior resident, if you understand this file, believe me, and you fill it in every patient you are dealing, I guarantee you the exam will become very easy for you. Okay. And these were my best friends, which I was telling you: normoxia, normocarbia, normotension, normovolemia, avoid sympathetic stimulation, maintain myocardial oxygen demand supply ratio, maintain sinus rhythm, maintain SVR, maintain preload and afterload, maintain right and left-sided filling pressures, okay, multimodal analgesia, and maintain organ perfusion for vital organs like brain, kidney, okay. So this is, I just got a chance to tell you. And I think I will just show you this thing and then we will finish. Okay, so this is the channel, okay. And if you want to, for example, search, you can go to the playlist, okay. And in the playlist, you will find like how to study English discussion, because before we used to discuss in our native language, okay. So you will find any topic here. Almost all the topics are covered. Cardiac, there are some deficiencies in cardiac, basic sciences, because you see, I am doing it all alone, okay. And I have no impulse other than just I feel it my moral responsibility to spread what I have, Allah has bestowed upon me, okay. But because a number of people tell me that because you don't take any money, that's why people they don't want to attend it, because they don't bother. So but anyways, I'm trying what's in my hand, and you can find everything. Like for people who are preparing for talks, you will find a number of important things. Because before I used to have in a slightly haphazard way, like journal. In one discussion, we used to discuss a number of topics. So in last few months, I have just tried to arrange, but I need manpower. Nobody comes to help me. I invite all of you in whatever way you want to help me, because it's for you. It's not for me. I have achieved whatever I wanted to achieve in my life. So I don't have much impulse. I'm not moving anything. Okay. So anyways, thank you very much. And we will meet soon, inshallah. Okay. Bye-bye.